Hello, hi everyone. We start the webinar of this Friday. The first lecture will be, there will be a change. The first lecturer will be Dr. Ramiz Malak. He is currently the head of neurosurgery at Charles Lemond Hospital, Quebec in Canada. And he is the assistant professor of neurosurgery at Sherbrooke University since 2010. He completed the residency program at the University of Montreal. Then he obtained a fellowship in epilepsy surgery at the University of Calgary. He also has a master's degree in biochemistry at McGill University. So the lecture of Professor Ramiz, epilepsy surgery. Please.
Hi, I would like to thank Dr. Fatima Abdullah for inviting me to this talk. Today I'll be presenting you surgical treatment of epilepsy. I have no conflict of interest related to this talk. First, I would like to present to you the place where I work, Charlemagne Hospital. This is at the south shore of Montreal city, and we are the referring hospital for about 1 million population. As you all know, doing epilepsy surgery implicates working with a big team. This includes the neurolog doing all the investigation before reaching the operation. There's the EEG tech, the nurses on the floor, the radiology tech, nuclear medicine, neuropsychology team, the OR team, and at the end, the surgeon. And I forgot to include also the pathologist who analyze at the end. The history of epilepsy surgery is relatively recent, knowing that the very first temporal lobectomy for epilepsy was done in 1947 by Percival Bailey in Chicago. He was working with the two non-neurologues, Gibbs and Gibbs. Montreal has also a very long history of epilepsy research and epilepsy surgery, starting with Penfield and Jasper, who founded the Montreal Neurological Institute in 1934, and then many very well-known epilepsy surgeons that followed their track, such as Rasmussen, Fendel, and Glor, and lately Dr. Olivier and Anderman. When we consider epilepsy surgery candidates, we classify them as either normal MRI, non-lesional epilepsy, or lesional epilepsy with abnormal MRI. We definitely prefer lesional epilepsy because they do have better outcome and easier pre-op evaluation. The most common surgical pathologies for epilepsy are mesial temporal sclerosis, tumors, focal cortical dysplasias, and cavernous malformation. In the last few years, we are starting to consider epilepsy, even focal epilepsy, as a part of networks. So even if we have a clear lesion, they might have some epileptical focuses away from the epileptic zone. According to the International League Against Epilepsy, the definition of drug-resistant epilepsy is failure of adequate trials of two tolerated and appropriately chosen and used antiepileptic drugs schedules, whether as monotherapies or in combination, to achieve sustained seizure freedom. In their famous study, Kwon and Brody have shown that the best chance to treat epilepsy with medication is with the first pill, and then there's another 14% chance to control seizure with the second medication, and then the chances get very small, and you end up always having 1/3 of epilepsy patient becoming resistant to medication. And from this 1/3, there's half of them that could be a good epilepsy surgery candidates. In another famous study by Weeb and al. In 2001, they compared seizure outcome in drug-resistant epilepsy patients going through either temporal lobectomy or medical treatment. They obtained an angle class 1 outcome in 58% of the surgical group compared to only 8% in the medical group. This has also been confirmed with large epilepsy surgery series with long-term surgical outcomes up to 10 years. And different groups have shown that epilepsy surgery will have seizure freedom somewhere between 55 and 76%. Here we can actually see the graphs from three such studies, and we can see clearly that over the years the effect of epilepsy surgery remains high even after 10 and 16 years. Now let's look at the different surgical approaches for epilepsy surgery. First of all, there's the intracranial electrodes, and then the different types of temporal lobectomies, then extratemporal resection, including insular resection that had lots of interest in the last few years. There's the callosotomy, hemispherectomy, hypothalamic hamartoma resection, and more recently radiosurgery, electrical stimulation such as VNS, DBS, cortical stimulation, and the most popular approach lately is the MRI-guided laser interstitial thermal therapy, or LITT. Intracranial electrodes can be divided as either surface electrodes or depth electrodes. This is one extreme case of a surface electrode that is covering a large area of the brain. And within the same case, we have also added depth electrodes. This is a reconstruction, and this is another example of surface electrodes where we used strips and they have been introduced through a burr hole instead of a big craniotomy. Surface electrodes can also be used during surgery as electrocorticography that can help to find the area where there's lots of electrical activities to be resected at the same time of the surgery, or can be implanted and do intracranial studies at the EEG lab. Those electrodes can also be used for mapping important functions in the brain, such as motor activity or speech. And this is a case where we had to remove a tumor in the motor area, motor cortex, and we used this grid to map the Rolandic area and remove the tumor safely. The other type of intracranial electrodes are depth electrodes, and this technique has been developed in France by Banco and Talerac, and we can use twist drills to introduce different electrodes in the brain, and now we can use neuronavigation to place electrodes exactly at the area we want. This technique has gained a lot of popularity in the recent years in North America, especially with the introduction of robot, where you can plan beforehand the different electrodes, and the robot will place them at the exact places that you have planned. This saves lots of time for the planning of and introduction of the electrodes. Now let's move on and talk about different types of temporal lobe resections, which remain the most used surgical technique for epilepsy in epilepsy patients. There is the classical anterior temporal lobectomy and the more minimally invasive selective resections. There are also different Approaches for the selective amygdalohypocampectomy can be used either by splitting the Sylvian fissure as the Yazergel technique, or the superior temporal sulcus approach, or the ones that we use and I will present to you in more details, which is the middle temporal gyrus approach. And the aim of those surgeries are to remove the amygdala, the hippocampus, and also the parahippocampal gyri. Some people has also described approach, transtentorial approach to the amygdala through the supracerebellar infratentorial transtentorial approach, but this sounds a little bit far-fetched for me. The technique I use is the middle temporal gyrus approach, or trans T2 approach, and I will walk you through the different steps of this surgery. First, we do positioning. We immobilize the head with the Mayfield clamp, and we use the neuronavigation to guide through the surgery, and we do a linear incision in the temporal area. We do the skin incision, and then we split the temporal muscle. Then we do a tailored small craniotomy using neuronavigation to guide for the craniotomy. Here the bone is removed, and we can see that we have a very minimal craniotomy of about 2 by 3 centimeters, which is largely sufficient to do the selective approach. Using the neuronavigation, we localize the medial temporal gyrus. This also can be localized using the skull base as a guide, which is seen here superiorly. And then we do 2 to 3 centimeter cortectomy with the bipolar and micro scissors through the length of the middle temporal gyrus. Then we go in the depth of the middle temporal gyrus by suctioning the white matter perpendicular to the surface using a small microsuction or the CUSA. As we go in the depth, we always verify with the neuronavigator that we are aiming towards the temporal horn of the lateral ventricle. This avoid going more superiorly or inferiorly. It's more dangerous to go superiorly and hit the basal ganglia. Here the ventricle is, the temporal horn of the lateral ventricle is open, and we can see the hippocampus through the opening of the ventricle. We increase the opening of the temporal horn of the lateral ventricle and its length to expose more of the hippocampus and anteriorly the amygdala. In this picture, we see clearly the junction between the head of the hippocampus and the amygdalar nucleus. Then we start by disconnecting the hippocampus and resecting the mesial temporal structures in a way to obtain a specimen to be analyzed in pathology. We resect inferior to the hippocampus, which we see at the top of the image. We, using the ultrasonic aspiration, we remove the parahippocampus inferiorly, and then anteriorly we remove the amygdalar nucleus by the same technique. And then we disconnect the specimen from the mesial hippocampal vessels. After having the hippocampal specimen, we continue removing the posterior aspect of the hippocampus using the ultrasonic aspirator, and we verify with the neuronavigation that we went posterior enough aiming as far as the quadrigeminal plate. After doing the hemostasis, we close the dura using a dural patch. Then we put the bone flap that we fix with small metallic titanium plates. Then we close the muscle, and finally we close the skin with sutures and staples. This is a post-operative MRI showing the extent of the mesial temporal structures resections. And this is a 3D reconstruction of the MRI showing the approach at the surface and the extent of resection of the amygdala, hippocampus, and parahippocampus. Callosotomy is another interesting surgical technique used in epilepsy. It is used mainly for generalized type of seizure and mainly the drop attack type, such as Lennox-Gastaut. So let's walk again through the surgical technique of callosotomy. Here we have the patient that is positioned supine. We have planned the incision using the neuronavigation again, and we have identified the sagittal sinus at the midline. After doing the linear incision, we tailored the craniotomy around the midline and centered at the coronal suture. Here we are removing the bone flap, opening the dura towards the sagittal sinus while avoiding to take the bridging veins that drain into the sinus. Then we dissect the interhemispheric space. Then we bring in the microscope and we continue dissecting deep into the interhemispheric fissure until we meet the callosal and pericallosal vessels. Here we have used cotton balls, anterior and posterior, to do gentle retraction of the brain. And finally, we see in the depth the corpus callosum that is glittering white fibers. At this point, we start suctioning the corpus callosum fibers at the midline, following the length of the corpus callosum using the ultrasonic aspirator. We continue resecting the corpus callosum over all its depth, which is about 5 to 8 millimeters, depending where we are in the corpus callosum, and which is variable from one patient to another. And we keep removing the corpus callosum while staying in the midline until we reach the septum pellucidum, and we can see here clearly the septum pellucidum and the ependyma of the two lateral ventricles. Again, using the neuronavigation, we can verify how far anterior or posterior we have reached of our resection. So ideally, you want to reach as anterior as possible to reach the rostrum of the corpus callosum. And posteriorly, we have to make decision before surgery. Either we're doing complete or anterior to third corpus callosotomy. This depends if you want to spare the splenium, which has language function. So if the patient has mental retardation and no speech function, usually we will go ahead and do a complete corpus callosotomy. Whereas if you want to if we have a functional language, then we would do a anterior to third and preserve the splenium. This is a 3D tractography representing the corpus callosum before and after two-third resection. And by scrolling down the images, we can see the extent of the callosotomy. Now, in the recent years, insular epilepsy has gained lots of interest. Many publications about semiology and surgery for insular epilepsy have been published. Uh, the insula is well hidden in the sylvian fissure, and it's covered by the sylvian arteries, so it is a relatively dangerous area to approach. Um, One way to reach the insular region is to split the sylvian fissure and then resect the insula in between the sylvian vessels. This is an MRI showing posterior insular resection. We can do either partial or complete insular resection depending on where the seizures are coming from. This whole insular epilepsy surgery was encouraged by the introduction of depth electrodes that can be inserted in the insula. Another technique to remove the insula is to take it at the same time as the operculum. For example, in this case, we have cortical dysplasia that involves both the frontum operculum and the insula. So by removing the frontal operculum that needs to be removed anyway, we can continue from there and remove the insula. And in this way, we don't have to split the sylvian fissure. Other interesting techniques for epilepsy are the hemispherectomy or hemispherotomy. Those techniques have been known for a while, and they are used for catastrophic seizures in pediatrics. Here we will not have time to go through details of those surgeries. Now, epilepsy surgery has relatively low complication rates. There are many studies that have addressed the complication rates from epilepsy surgery. This is one large study from Montreal that have looked at complication at long term from a series of about 2,500 epilepsy surgery procedure, and they found that the risk of surgical complication is about 3%, including hematoma, infection, subgaleal fluid collection, or post-operative edema. In the same study, they looked also at their neurological complication, and they found also less than 3% minor and about 0.5% major neurological complications, and this include hemiparesis, dysphasia, hemianopia, quadranopia, or cranial nerve palsy. Of course, this depends on the type of surgery performed. Now I want to move on to talk very quickly about the newest surgical techniques for epilepsy. This includes electrical stimulation such as VNS, DBS, or cortical stimulation. Also, there is radiosurgery. We use endoscopy for certain type of epilepsy, and more recently, more and more centers are using the laser interstitial thermal therapy, or LITT. VNS is a relatively old technique now. and it is used mainly in generalized epilepsy and mainly for drop attack type of epilepsy, similar to the corpus callosotomy. It has also been used lately for other pathologies such as depression. This technique involves putting a wired loop around the vagus nerve that we dissect in the neck, and there's a chargeable battery that is placed in a pocket either in the chest. Deep brain stimulation, or DBS, has also been used in some cases of epilepsy surgery. It can be used, for example, instead of resection of left hippocampus in cases with high risk of memory deterioration, or in cases of bitemporal epilepsy. RNS, or responsive neurostimulation, is another technique where the device can detect the seizure and respond by electrical shock to abort the seizure. We can use two electrodes, either superficial or deep, or a combination of both. Radiosurgery has also been used for treatment of epilepsy surgery. This can be used to treat mesial temporal sclerosis or other brain lesions. Cerebral and ventricular endoscopy can be also used in some cases of epilepsy surgery, such as removal of hypothalamic hamartoma. Finally, the newest technique in epilepsy surgery is the introduction of the MRI-guided laser interstitial thermal therapy, or LITT. For this surgery, we use a stereotactic frame and image fusion to guide the to plan the trajectory of the laser, and the laser is then introduced via a small twist drill on the skin. Then the patient is taken to the MRI room for real-time visualization of ablation using MRI thermometry. We want to obtain a target temperature of 60 to 80 degrees that causes tissue destruction. We can also obtain immediate MRI scan showing the exact extent of ablation. The advantage of this new technology is that we have a discrete lesion margin, immediate efficacy for control of seizures, lower risk of complication, and faster recovery. Normally, the patient can return home next day. In conclusion, there are various new and old surgical techniques that has been developed for epilepsy to treat refractory seizures. Multiple surgical options are available and can be offered based on the clinical presentation, the type of epilepsy, and the patient and surgeon preferences. We can obtain high rate of seizure control with relatively low morbidity. Thank you for your attention, and now we can move on for questions.
Thank you, Dr. Professor Malak, for this nice presentation. We have left with some good time for questions and answers. We are waiting for any questions from the audience. This time I will make use of my role as a moderator to ask some few questions, if you allow me. Yes, is there still a place for MST, which is the multiple subbial transection, in the field of epileptology, say in Landau-Kleffner syndrome or ESES, etc.? You are unmuted. The sound. Yeah.
Now? Okay.
Yeah.
So yeah, thanks for asking this question. Sorry I didn't mention it in my presentation because I think it's with all the techniques that we have, it's rare that we have to do this kind of techniques. I've seen it only once during my training in case where we had lesions in very functional areas. There is risk also of deteriorating. We use it mostly in cases with motor Rolandic seizures, where we do strips on the cortex parallel, but there's definitely a risk of weakness. And now also we have many other alternatives. So in my practice, as I said, I don't use it that much, and I've seen it only once during training.
Okay, thank you. Well, a second question, I wonder if you have practice in child or in infancy surgery, epilepsy surgery. It is said that within the first 3 years of life, there is the brain plasticity trait will manage to compensate between the functions of two hemispheres, so that resections which are done in the first 3 years of life are of better prognosis than those in adults. Am I right?
Yeah, definitely. So I work in an adult hospital, but during my training, I did have some exposure to pediatric epilepsy surgery. And what I can tell you is that there are different factors to consider when to decide the timing of surgery. So very early surgery, the problem is the weight of the child, and let's say in the first 3 to 6 months, the child are very small, and the risk of they can tolerate very badly blood loss. So usually we try to get them at least after 3 to 6 months to have enough circulating blood so they can sustain big surgeries. And definitely, the more you wait to treat epilepsy, the worse is the outcome from surgery control, but also from cognitive deterioration, because we know that the multiple seizure in a young brain can cause cognitive deterioration, which is we call epileptic encephalopathy, that develops and have been studied in many places. So yes, the early the better, but at the same time, too early is a little bit higher risk also for the very, very young children.
So what is the age, smallest age, or the age that we can do surgery for?
Yeah, as I said, I haven't done pediatric surgery for the last 10 years, but from memory, I would say 6 months, not before 6 months, because otherwise they would be too small and higher risk for the blood loss and to sustain the general anesthesia for many hours.
Well, I have a few questions, but I will go to see if there is, a question from one of our Nuha Hassan. What's the risk of gliosis after traditional surgery?
I'm sorry?
What is the risk of gliosis after traditional surgery, making a new epileptogenic lesion?
Yeah.
The fibrosis of surgery itself.
I understand. So scarring from surgery that cause other epilepsy. So
Yes.
this has been discussed many times. And my practice is not frequently a problem. So usually, let's talk about, for example, the cases that we do most frequently, either lesions from tumor lesions or mesial temporal sclerosis. Usually when those patients fail, let's say they usually have a good control after surgery, but then they have recurrence of seizure. So most of the time in case of tumors, this is because there's recurrence of the tumor, and then patients start to seize again. We have very rarely seen patients where we operated for tumor and they had seizures at the same time. They come back for, they had the long-time seizure freedom, and then they come back later with epilepsy only due to gliosis. Most of the time it's really due to scarring tissue. And also in mesial temporal sclerosis, most of the time where people recur after selective amyloidocampectomy, let's say, or temporal lobe epilepsy, most of the time it's because there's remnant and there's not enough resection of the hippocampus and parahippocampus and amygdala. And usually what we do, we put electrodes and we verify that the seizures are coming from those structures, and we go ahead and we complete the resection. So there are cases we have failure because not efficient resection of the so yes, there have been lots of theories about the gliosis, and it does make sense because even a trauma without surgery, somebody who has a trauma and has scarring from trauma also can develop epilepsy. But in my practice, and I have not seen that.
Thank you. Another question from an Iraqi neurologist, Dr. Adil Yassin. He said that in your table, the number of patients is less than the number of operations. Do this mean, so does this mean that they repeat failed operations? I mean, there is some re-operations on the same patient?
You're talking about the table with the complication, the risk of complication. I think he's talking about this one, yeah. So yeah, usually when people present their results for complication or for other types, usually, yes, you have, this is not my data. This is the one for the complication is the one from the Montreal Neurological Institute. And they looked at all their cases, and they are patients, definitely some patients had repeat surgery, either because they had electrodes inserted first and then resection, or a resection that failed and they had to do other resection. But majority, I would say, due to the fact that they had electrodes first and then a resection.
Well, a question from Shahinaz, the chair of International League Against Epilepsy, Mediterranean region. Is there any advance on technical aspect of surgery about hemispherectomy on dominant hemisphere?
Yeah, so I did not go into much details about that because this is pediatric epilepsy, and I haven't touched that for a while since my fellowship. But yeah, so there's the hemispherectomy and hemispherotomy. Hemispherectomy, where we do remove half of the, we remove one hemisphere, complete hemisphere, and the hemispherotomy, where we do disconnection between the different hemispheres, which includes a temporal lobectomy and callosotomy, and also posterior disconnection. There are different techniques that have been described, and some people, up to this point, there are some people who believe more on the hemispherectomy and others that do hemispherotomy. There are advantages and risks for both techniques. But there's also the hemispherotomy that is transinsular hemispherotomy that have been developed by Villemure and al., where they go, they do, it's kind of minimally invasive, if you want, technique to approach from a single, for a small craniotomy, where we can go above and posterior and inferior to the insula and do all the disconnection with a relatively small craniotomy. But again, this is really more done in pediatric, and I haven't touched that for a while.
Well, another question from Dr. Sami. Do you have patients with complete recovery after surgery without need for aids? And I have a personal question after that regarding this one.
Yeah. So yeah, we have collected our data lately, and we have, I would say, a majority of our patients, 80 to 90% of our patients that are seizure-free with a follow-up of up to 10 years now. Not all of them, we stop their medication. Majority will tell them we stop it, we start to lower it only after 1 year. As recommended, and then we lower it. But many patients decide on their own, I don't have seizure, I just want to stop it. And surprisingly, many of them don't develop seizure anymore. And actually, my neurologists say, I just lose them, I don't see them anymore, they don't come to see me. So, they decide to stop their medication. And the majority in our series, up to 80%, no seizure within a follow-up of 10 years. And we have, I would say, I don't have the exact numbers, but I think at least half of them, they probably, let's say 30% of them, they stop completely the medication. Either they tell the neurolog or they don't tell him.
Mm-hmm. Well, my question relative to this answer of you, after surgery, resection of temporal lobe resection, is there any cognitive changes in the left temporal resection versus the right temporal resection in your practice or knowledge?
Yeah, so we do evaluate all our patients with neuropsychology tests pre and post-op, and there is usually there's about 20 to 30% of those patients operated on the left side who would have some memory issue on paper. So when they do the neuropsych test, they tell us that there is a significant decrease in verbal memory and sometimes in speech function. But when you do ask the patient, they don't see any difference in their real life. When they talk to you, you don't see that they're having. Some of them will tell you, oh, sometimes I have difficulty finding words. Some of them will tell you, oh, I have to take more notes. But even those who score, the score is kind of scary on the neuropsych, they say in their real life, they don't see much difference.
Oh, I just want to cite a comment from Professor Mr. Silwa, which is working a prominent epilepsy surgeon in King College Hospital. He a lot of operations really. He comments one time that there is some sort of an increase in the suicide and those who are very free of seizures, since they find themselves, say, with no more care after being cared for, and no more chance for a job, no more chance for say education that is not enough, and socially they are not well accepted, still repelled. Do you have a comment about this?
Yeah, thanks God nobody of my patient commits suicide. That's
Good.
But we did see, actually that's true, we did see patients with deterioration of depression or appearance of depression that was not there. I have in mind one patient who is completely seizure-free, everything's fine, but he had very bad depression, not enough to go to suicide, but it was very bad. And even he wondered if it was worthwhile to do the surgery, even if he's seizure-free. Fortunately, he got better after it took him a couple of years to get out of this depression. We did review of the literature, and there is clear reports on about 10% of patients getting some kind of deterioration or appearance of new depression or anxiety. So when I counsel my patients before surgery, I do mention those numbers. And if we have patients, this is usually the risk factors for that is mainly patients who already have a history of anxiety or depression. And when we do have that red flag, we ask consultation of psychiatry and psychology pre and post-op to make sure that they don't go downhill afterwards.
Okay. Well, one question, can surgery be beneficial in infantile spasm?
Well, I guess from your question that you're working with pediatric, right?
No, this is not my question.
Yeah,
This is one of the audience. Yeah.
Yeah. I don't have an answer to your question. As I said, I haven't done pediatric surgery for more than 10 years now. I don't want to give you an answer off my hand without knowledge. I don't have answer to your question.
Well, about LITT, LITT, can be done for multiple foci of seizure?
Yes. So now the LITT is the big star in epilepsy surgery and even in neurosurgery for tumor and for epilepsy. And I think the ones that are used the most in epilepsy is really for mesial temporal sclerosis. They had, I didn't talk much about it, but I knew people would be interested into that. So the numbers are encouraging from the complication rates and from the response. The response is a little bit less than open surgery. And unfortunately, the technique is not available at all centers, but there's big interest in this technique. We're trying hard to get this technique in our hospital. I've been working to get it in the last 3 years, and hopefully we'll get it soon. And people have described it and describe it a lot in mesial temporal sclerosis, where you can use many targets because the hippocampus is as you know, is a C-shaped structure. So people have used it to plan different lesions within the hippocampus and amygdala sometimes and the parahippocampus, and usually try to make it all on the same track. It have also been used for callosotomies. People have used it for callosotomy, where they also make either with a single track or multiple tracks. Can it be used for multiple lesions? Technically, yes. Could be used, for example, in cases where you have focal dysplasia, where have multiple cases of focal dysplasia, or cases with tuberous sclerosis, I guess, if you're thinking about that when you ask the question. So technically, yes, it is. I haven't seen many reports on cases where they do multiple lesions, but definitely it's technically feasible.
Well, one question from Sausan, maybe the last question. How would you approach a patient with a bilateral hippocampal sclerosis and uncontrolled seizure or refractory epilepsy with both sides hippocampal sclerosis?
So initially we used to tell him he is not the surgical candidate. And now I think we have many options. As I described, there's the DBS, I think, is an interesting option because you do not make lesion in the temporal lobes. Because if you do destroy both temporal lobes, as you know, you can have the Clover-Bucy syndrome, which is not very nice. And you can have severe amnesia and so on. Before I've seen reports, old reports where they would go with the side where there's more seizures. So there have been reports where they would do single temporal lobectomy or selective to remove the place where there's more seizures coming from. They say if you have 70% on one side, 30% on the other side, you can go ahead and take the place where you have 70%. And people did have some success with that. The other option is, as I said, you can go with DBS because you do not destroy the lesion, you just do electrical stimulation. And so this would be an interesting option. Again, not all the centers, they have this technique, this technology.
Oh, I think one question which I didn't understand very well is in comparison with the VNS, what do you prefer and why? If you understand something of that question.
VNS versus corpus callosotomy?
No, in comparison with VNS, what do you prefer and why? This is the question. I don't
VNS
understand.
compared to what?
I don't
So
know.
VNS
The question is as such. Yeah.
So VNS is classically compared to corpus callosotomy, and so corpus callosotomy is a relatively bigger surgery. There's a higher risk, but you have better result for seizure control. So with the corpus callosotomy, let's say for the drop attack and generalized seizures, you have about 75 to 80% chance of decreasing the seizures by 75 or 80%. Whereas VNS, you have a smaller chance of improving seizures. They talk about 50% chance of decreasing the seizures by 50%, but it's a relatively less risky surgery, and it's not reversible. So you're doing stimulation where you're not destroying structures. So it depends on the patient, how sick he is, what is exactly his pathology. Is he willing to take the risk of doing the callosotomy or not? And so it's all about, so other factors to be considered is the surgeon comfortable by doing one technique or the other? And also the VNS is very costly technique. And I don't know about you guys, but here we have quotas to how many VNS we can implant at each region. So this also could be a limiting factor.
Okay, thank you very much for this very nice presentation. And you really give us enough time for the answers and questions, which is usually, more beneficial even than.
I find this is the first time I register myself first, and I think it's very nice because exactly it's more practical. I think it gives more time at the end.
Yeah, thank you very much.
Thanks for inviting me again.
Thank you.
Have a good day.
Good day. Bye bye. Well. Dr. Adil, I shift to you if there is, if you present.
Okay, thank you, Raib. Thank you, Dr. Ramez, for this excellent lecture and presentation, really. And I pass for the next speaker and the next presentation. It's my pleasure to introduce Dr. Nermeen Adel Kishik from Egypt. She is currently a full professor of neurology at Cairo University since 2014, after completing her residency training at the neurology department in Cairo University hospitals. She has multiple fields of interest. She focused on epilepsy clinic since 2004. After that, 2010, she became the moderator of the epilepsy clinic and chair in the upgrading into epilepsy unit. She joined many international education, EEG and epilepsy courses and schools. She is the Vice Secretary General of the Egypt Society Against Epilepsy, chapter of the International League Against Epilepsy, and joined ILAE COVID task forces as a representative of Eastern Mediterranean. She is the principal investigator for ongoing national research in her university focused on drug-resistant epilepsy. Her presentation is titled Sudden Unexpected Death in Epilepsy. Dr. Nermeen, it's a pleasure. You can start.
First of all, I would like to thank the organizing committee for kind invitation to share in ILAE scientific activity. Today, we'll try to answer this question: how do you catch the silent killer in people with epilepsy? I have nothing to disclose. All of us know that people with epilepsy face greatly increased prevalence of premature mortality. And the most recent real-life example for this silent killer represented through the tragic death of the Disney star Cameron Boyce, where Sodip was one to blame. Cameron, diagnosed as epileptic at 17 years old, his seizures were infrequent but were exclusively nocturnal. His parents reflected their grief by launch a campaign called No Sudib Now. And from my perspective, I try to answer this question, what is the magnitude and the classification of mortality in people with epilepsy? Know your enemy, who is the silent killer, who are the highly susceptible victims between our patients, and how can we catch the potential killer to protect our patients? As we all know, the epilepsy mortality may be direct cause, which is the most catastrophic cause and still not well understood, sudden unexplained death in epilepsy, accident or drowning, the acute or the emergency related like status epilepticus, symptomatic seizure or seizure clustering. Also indirect cause as suicide, which is reflecting the suffering of our patient as the stigma, severe depression, also the chronic adverse event of anti-seizure medication or the other neurological comorbidity between epileptic patients. It was found that overall mortality between people with epilepsy ranging from 1.6 to 11 times greater than the general population. And also standardized mortality ratio became doubled between new onset diagnosis and also increasing to triple for the chronic epileptic, especially with remote symptomatic etiology. Also, as we can see in this figure illustrating the result of 4 different studies, community-based and population-based study between childhood onset epilepsy, which the result, as we can see, the SUTIB account for the most epilepsy-related deaths, especially with long duration of epilepsy and between adolescents. So we try to know what is SUDIP and what its incidence and also the pathophysiology. In a very simple way, SUDIP defined as any epileptic patient died suddenly without a good reason. Sudden, unexpected, non-traumatic, non-drowning, with or without witness, with no structural cause, no status, and but mostly in a benign circumstances related or not to seizure. This is the clinical criteria to define SUDIP. Near SUDIP means that the patient who survived after 1 hour from cardiorespiratory arrest. However, near fatal SUDIP is a patient who passed away after 1 hour of cardiorespiratory arrest. We can categorize SUDIP according to the confirmation of the diagnosis into possible SUDIP with a competing cause of death like comorbid hepatic renal disorders that may share in mechanism of death. Probable SUDIP meet all clinical criteria as I mentioned, but with no available post-mortem autopsy. Defined definite SUDIP, which confirmed by post-mortem autopsy without any anatomical or toxicological causes. Also, SUDIP plus, another term used in many studies, which could have SUDIP with another condition, which could have contributed to the death, For example, autopsy showed coronary insufficiency without definite myocardial infarction. From different SODIP registry, it was found that in the North American SODIP registry, Danish and also in Denmark, many registry studies the SODIP distribution between different population. And we found in most of the study that usually SODIP targets preferentially younger people, ranging from 20 to 50 years old. In a childhood epilepsy, it's a rare risk. 2 child every 10,000 per year. However, in the adult with epilepsy, it is considered a small risk, 1 every 1,000 every year. So don't overestimate or underestimate the risk of SODIP. Also, as regarding the epilepsy population, there is different epilepsy subpopulation. As we can see here, the incidence of SODIP between epilepsy clinic is less than which epileptic patient with intellectual disability, and the incidence increasing to 4 per thousand and up to 6 per thousand in drug-resistant epilepsy and who needed surgery or vagal nerve stimulation. Also, this figure showing the result of 26 studies in different epilepsy population. As we can see here in outpatient clinic, there is a low risk, a high risk increase in the risk increase in DRE group, and the increasing more in the surgical group. So after that, SODIP is still, all of us know that SODIP is still not well understood. However, SODIP can occur related to the seizure itself, the presence of epilepsy, and also there is a common factor between heart and the brain. Let us start with how seizure itself may cause SODIP or explain the occurrence of SODIP. In most researches represented that seizure when the firing occurred in any cortical region, especially on the right hemisphere, temporal insula, has a pressure response, manifested as tachycardia, tachyarrhythmia, or if the seizure originating from the left side, most of the study proved that can be causing a depressive response and causing bradycardia or asystole. Also, as you can see on the left side of my screen, the cingulate, the thalamus, especially the posterior nucleus, which is sensitive to hypoxia, and also the propagation to the brain stem nuclei can affecting the cardiorespiratory regulation. This figure illustrates the way of seizure propagation, which may be reached to the cardiovascular control, sympathetic and parasympathetic, lead to ictal arrhythmia. As we can see, the percentage of bradycardia or asystole is lesser but more dangerous. And also when propagated to the respiratory center, the arousal center, leading to decreasing more inhibition of this neuron, leading to decreased serotonin, noradrenaline, acetylcholine, and glutamate. All of these may lead to impair in the arousal, impair in the carbon dioxide sensor. Consequently, on the clinical aspect, all of these cause ictal apnea and also post-ictal coma. Some patient has a semiology in the area of bilicervian, which insular epilepsy, causing laryngeal spasm and consequently causing obstructed apnea. What about the post-ictal state? As regarding the post-ictal suppression, which reflect dysregulation of cardiorespiratory and autonomic connection and cause fatal consequences. At the level of the lung, there is hypoxia, hypercapnia, pulmonary edema, which also decrease in the respiratory drive. At the level of the heart, the patient may develop a post-ictal arrhythmia, which is more dangerous than ictal one. As ictal one, usually self-limited by the cerebral anoxia caused by the ictal asystole. Also, post-ictal coma with delayed arousal due to loss of protective airway commonly occurred in patients developed GTCs during REM sleep, especially if he was on the prone position. As regarding in the epilepsy monitoring unit, excessive neuronal inhibition leading to an EEG shutdown, which can manifested by post-ictal generalized EEG suppression. As we can see, there is a seizure followed by EEG suppression, which called post-ictal generalized EEG suppression. And in some researches, it may be considered as an equivocal biomarker of pseudo-breast. And this finding is become more confirmed or in the Morton's study, which is a retrospective study, mortality in epilepsy monitoring unit. Study including 147 epilepsy monitoring units all over Europe to investigate the main mechanism of cardiorespiratory arrest between 29 patients. 4 of them proved non-SODIP, 9 of them diagnosed as near SODIP, 14 out of 16 diagnosed as definite or probable SODIP at night. The most consistent finding is after GTCs, there is a increasing in the breathing rate up to 50 breaths per minute, followed by cardiorespiratory dysfunction within 3 minutes, then terminal apnea occurring within 11 minutes of the end of the seizure. And when analyzed this result, the most important causes of such catastrophic event were aggravated by suboptimal supervision during nighttime and withdrawal of anti-seizure medication. Let us share with me the data of this lucky man. He's a 40-year-old epileptic man diagnosed as epilepsy at age of 23. We examine him. There is normal neurological examination, normal MRI, conventional EEG. His seizure type was focal, unaware with bilateral tonic-clonic seizure. He receiving the medication full doses up to 3 medication. However, his wife reported that he in the last year started to develop total loss of consciousness, pallor, and falling down without definite motor phenomena. So we record the event in our unit for this lucky man, which reveal that. I will try to, the video starting. The event occurred, 15-minute loss of contact. Patient became unaware with a stereotyped motor autonomic in the right, then left hand and lower limb. His father trying to asking him to respond, but the patient not responding, unaware, still arrest of behavior here. And then head turn to the left side of the patient with tonic posturing, then atonia stumbled to the right side for just a few seconds, and then followed by extensor tonic posturing of the right upper limb with brief myoclonic jerk. And this is a compressed EEG epochs showing the rhythmic alpha activity, ictal rhythmic alpha activity on the left temporal, followed by evolution to theta and delta and spreading to the right hemisphere. But the most striking finding here, as you can see, there is a 5 seconds of after the few seconds from the start of the ictal rhythm, there is 5 seconds of bradycardia and 9 seconds ictal asystole, as you can see. We try to apply the pathophysiology and try to explain the mechanism of this ictal asystole, and we found that the patient developed focal unaware seizure, which propagated to a cerebrogenic area causing vagal stimulation, ictal brady then asystole. When ictal asystole occurred, consequently, there is cerebral anoxia, hypoperfusion, which usually terminate the seizure, and then the patient become atonic and then enter in what is called convulsive syncope, a posturing due to a second after regaining the heart rate. So this is, I think, it is a good example of potentially preventable and treatable cause of risk of SUDIP. Our patient has asystole more than 6 minutes, so he is candidate for double chamber pacemaker, and already the patient performed by our cardiologist and become very well, the seizure control. The attack not occurred since the application of pacemaker, apart from the focal unaware, which is occurring infrequent every 6 months. The presence of epilepsy itself. As we all know, drug-resistant epilepsy associated with low vagal tone and a high sympathetic tone, which lead to, both of them, decrease in the heart rate variability and also tachycardia. Both of them can be a risk for sudden cardiac arrest. And this confirmed in the ARREST study, which diagnosed epilepsy. This study just studying the different causes and risk of sudden cardiac death between more than 1,000 individuals. They diagnosed 12 epileptic patients in the group of sudden cardiac death and in the control group. And after assessing the relative risk for sudden cardiac arrest between the patient group and the control group, they was found that epilepsy was associated with the threefold increased risk for sudden cardiac arrest, especially particularly between young and female. What about the common factor between heart and the brain, which can predispose or increase risk of SUDIP? As we all know, the cardiomyocyte action potential is similar to the neuronal action potential. And there is an entity between them called neurocardiac channelopathy gene. So different patients may develop long QT syndromes or maybe develop seizure or both together. And in one of the study found that the whole exome sequencing for who died of SUDIP had unique variants in both cardiac conduction and synaptic transmission signaling pathway. And also from our side, there is some evidence that 49% of deaths between Dravet syndrome due to SUDIP. We must be aware to read basic ECG. And the most common finding we need to search for is the QT interval. As we can see, there is a corrected QT interval, different in the cutoff point between male and the female. And also the T-wave morphology. There is what is called T-wave alternate. As you can see, there is low amplitude here, high normal amplitude, and so on, what's called T-wave alternate. Both of them considered as a risk factor for ventricular arrhythmia. And such ventricular arrhythmia can progress to ventricular fibrillation and leading to sudden cardiac death. In our center, we study the frequency of cardiac repolarization disorder, especially the long QT, corrected long QT interval between among 1,000 people with epilepsy versus control, and trying to associate between their occurrence and any of the demographic or epilepsy-related features. We found that there is a significant increase in the prolonged QT interval in epileptic patient compared to non-epileptic. And when we do some sort of regression analysis, after controlling all other factors, we found that the age and uncontrolled seizure has a role can predict the presence of prolonged QT interval. As we can see, every 1 year increase in our in age between our patients, the risk of prolonged QT increased by about 3%. And people with uncontrolled seizure, the risk of prolonged QT increased by 80% compared to the controlled seizure. After we try to understanding the pathophysiology of SUDIP, who are the highly susceptible victims? Identify which patients are at risk. There is a different study studies the factors which is maybe modifiable or non-modifiable risk factor for SUDIP between the patients. The first and the most important one is the presence of generalized tonic-clonic seizure, especially if uncontrolled, and especially if occurred nocturnal, and the patient was in prone position. Patient who developed a polytherapy, depressed, and also the non-modifiable long-standing EEG, long-standing epilepsy, an age of onset is lesser than 16. Most of the study showed that the male sex more than in female prone to SUDIP. The genetic susceptibility of long QT interval prolongation, and the low IQ or abnormal MRI. And don't forget the insular epilepsy. After we revise together the modifiable and non-modifiable risk factor, one of the most hot topic now in epilepsy community is trying to determine potential biomarkers for risk stratification of patients susceptible to SUDIP. the most well understood clinical biomarker is the uncontrolled generalized tonic-clonic seizure. The vast majority of SUDIP occur in aftermath of GTCs, which illustrated here in the Kaplan-Meier curve. As we can see, more the risk increase when the GTCs occurred more than 3 times per year. And in another way of expression, 3 GTCs per year have a 15-fold increased risk of SUDIP. Also, there is another entity of biomarker still need more study. However, in structural MRI, there is finding like cortical thickening and thinning in generalized tonic-clonic seizure, subcortical volume alteration, brainstem and the cerebellar volume loss. All of these have main concept, which is loss or impaired connectivity in some area like thalamus, brainstem, and the frontal region, and on the other side, tissue gain and increase connectivity in the limbic system, insula, and the sensory side. All of these claim as a high risk of SUDIP. Don't forget the very simple biomarker long QT interval, and also the equivocal biomarker, which is the generalized suppression post-ictally. In one study, there is an autopsy analysis. They found that a significant upregulation of a certain microRNA in plasma and the hippocampus of a SUDIP case compared with control. So, after we study the risk factor, to tell or not to tell, when, how, and what to tell. What to tell to our patient. I came across which explains the concept of SUDIP, and I see all these fishes. So I think we need to incorporate a brief semi-structural risk assessment in routine clinical practice, such as seizure safety, a checklist, and also the NICE guideline recommendation tailored information according to person's risk of SUDIP is the best way. At the end, and the last question, can we prevent epilepsy-related mortality? Can we catch the potentially killer? The answer is yes, through 3 lines. The first line is the medical treatment. As you can see, this is a meta-analysis including 112 randomized controlled trial, trying to study the effect of compliance and taking efficacious anti-epileptic drugs compared to placebo. And they concluded that active treatment reduced mortality by up to 7 times, mostly due to reducing seizure frequency and severity. And by the way, all of us know that proper medical treatment can be effective from 50 to 70% of our epileptic patients. Medical treatment, which drug, what is next? Please, after we revise the common association between heart and the brain and what is called the neurocardiac channelopathy, try to avoid drugs which causing depolarization block, like phenytoin, carbamazepine, lamotrigine, and the other drug, lacosamide, rufinamide, and also polytherapy for the effect of drug-drug interaction, especially in the genetically prone individuals. And try to push your patient to be adherent well to the anti-seizure medication. And don't forget the pacemaker implantation, which save our patient. And when the patient became DRE and not surgery candidate, try to shift to another non-pharmacological strategy like neuromodulation and also ketogenic diet, especially in the pediatric age group. The second line is the surgical line. As you can see in this interesting study about temporal lobe epilepsy outcome, patient showed that the standardized mortality ratio is 3.6, which means that the patient with seizure were 3.6 times as likely to die during the study period, which is 12 years, than the normal population. And if the patient proceeded to surgery and became seizure-free, the risk declined to the level as in general population. However, this didn't occur in another group, which the seizure is persist, and such miserable group has increased risk of standardized mortality ratio up to 7.4. And we can explain this by the long duration of epilepsy before surgery decision. So I think it is a very good lesson to push our patient as early as possible for the non-pharmacological treatment, especially if he is surgically candidate. The most important, and I think is a very in a daily practice line of treatment or management or prevention, is the awareness and education. First step, we try to learn the patient, the caregiver, or even the young generation to educate the patient that safe sleep environment is very, very important. We can use a breathable pillow and also avoid a lot of soft bedding. Try to avoid the prone position during sleep. The second, nocturnal supervision, which reduces the risk of SUDIP up to 60% through room partner at least 10 years old with normal IQ, regular check, and we can use nocturnal listening device causing 90% reduction. And also in the recent era, there is a sensor for clonic motion. And don't forget, the most important point is the anti-seizure medication adherence. At the end, I need to conclude by these three statements. We must rapidly improve physician, patient, and caregiver awareness about SUDIP, stop seizure, especially nocturnal and generalized tonic-clonic seizure, overnight observation, consider early non-pharmacological treatment in DRE. Second, simultaneous video EEG and ECG recording is very, very important. Third, routine ECG should be required for people with epilepsy to help in choice of proper anti-seizure medication, especially who have family history of sudden cardiac death. And at the end, save this date to save our patient by revising the recent recommendation about SUDIP, the awareness about the SUDIP between patient and young physician. And thank you.
Thank you, Narmin, for excellent presentation again. And I'm looking at, we have just two questions now. I'm starting with Dr. Shehnaz. She asked if there is any data from Mediterranean region about the SIDM. Do you have something to tell us?
Unfortunately, there is no well-studied registry for SUDIP, However, in our country, we starting in our university a study, and soon we will publish this study about the different risk factor between our patient in for SUDEP.
And the second question from Fatima Kamoun. She said in child with epileptic encephalopathy or simply epilepsy with the frequent status epilepticus, tonic and myoclonic atonic, we don't note SIDEP. Any explanation do you have?
Yes, it is by the registry, as I mentioned in my third or fourth slides, already the risk between childhood onset epilepsy is a little bit more rare than the adult or adolescence period. So I think this is the cause, and also the mortality rate in a child with epilepsy a little bit less than mortality rate in between adolescents and adults.
And another question from Sami Salam. Do we have any lab or biomarkers for prediction SIDEP?
Until now, no, there is no definite laboratory biomarker, except I searched about this. I found one study comparing just 8 individuals post-mortem about microRNA. One died by SUDEP, and the other 7 post-traumatic deaths, and just a very small sample size. So I think there is no definite laboratory biomarker for SUDEP. The most simple way.
Question.
Yeah.
You have some problem in the phone.
You hear me? Do you hear me?
I hear you bad. Now maybe, yes.
Yes, okay. I mean,
okay.
Okay.
From Sausan Al-Bazi, can VNS increase risk of SIDEP? Is there a way to decrease that risk, if any?
No, there is. It is. I think it is, the study proves the opposite way, because the mortality rate and the SUDEP especially decreasing with using of application of vagal nerve stimulation.
Again, another question from Fatma Abdullah. When do you tell the patient regarding SIDEP? Do you discuss it with all patients?
Definitely, we start first with the patient.
Again, you have a bad phone.
You listen me now? Okay.
Maybe. Okay, I hope.
Yes, better. Yes.
I will try to raise my voice. Okay. I think I start to discuss the SUDEP issue with a patient, especially in adolescence or adult, with generalized tonic seizure or mainly nocturnal seizure, and especially who the patient with not adherent to his medication, or feel like no problem to skip 1 dose or 2 doses. I think this is the main group we need to discuss. The second group is already the patient with drug-resistant epilepsy, to convince them to shift from medical treatment to a non-pharmacological treatment like vagal nerve stimulation, ketogenic diet, or surgery. But not all patients must be discussed in a frank way, but just tell the patient that your life is you can expose to trauma, you can expose to sudden arrest in the heart due to non-compliant or due to lack of self-confidence. Because I think patient to risk in SUDIP increased also in patient who depressed, because the depressed patient, the most common patient that not adherent to medication. So if the patient is depressed, he will not adherent to the medication, and this is considered a risk of SUDIP.
I have from Osama Landuzi. Is there a specific sign from neuroimaging predicting high risk of SUDIP?
As I mentioned, there is a many study about the volumetry study about some cortical, subcortical region, brainstem and cerebellar, but still a few study. There is not definite, it is just a small correlation. And also the connectivity. There is some low connectivity and the high connectivity in region, as I mentioned in my talk. Some connectivity, decreasing connectivity between thalamus, insula, and also increasing connectivity between insula and the brainstem, which increasing the propagation to brainstem nuclei and causing more suppression of the arousal system. But no definite biomarker, neuroimaging biomarker.
Okay, thank you. From Noha Hassan, do we do ECG as a following up test for only genetically predisposing lung QT patient or for a patient?
It's better. There is no definite recommendation for this, but it is recommended for a patient who has a history of family member sudden cardiac arrest, or even the patient developing any cardiac arrhythmia. So if the patient became epileptic, we must do an ECG before starting the anti-epileptic medication. And also, I think, in my opinion, we need to do an ECG for especially for the patient with drug-resistant epilepsy, because it may be all these patients on polymedication. So we must rule out the long QT or any problem in the repolarization potential.
I can have some comment here. I think it must be a routine electrocardiogram. It is so important in the initial evaluation of patient with epilepsy. In addition, it is a rule in the diagnostic evaluation of seizure. I think it must be a routine test, EEG with the video, as you mentioned in your presentation, to do the EEG with the video, the ECG with the video EEG. I think it's so important because it must be a routine test for all patients.
I differentiate between when we do an EEG, we must do an ECG with the EEG.
Yes.
Yes.
I have a question. You mentioned before the SUDIP in children and in adult, but you didn't mention the elderly patient. Did you have any study about the elderly patients?
Yes, there is some research about talking about the elderly, and said that the elderly is not immune from SUDIP. Elderly epileptic patient not immune from SUDIP. However, an elderly patient mostly not searching for SUDIP by post-mortem autopsy, because mostly there is some other causes of deaths, like cardiac cause or respiratory cause. But elderly not immune from SUDIP, because it is in the registry North American or Danish, there is an older people passed away due to SUDIP.
I have some other question. I saw that there is a question in the, what about the association of SIDA with sleeping and sleeping related seizure?
Is a very, very important question. The most common risk factor is the generalized, and also especially if during sleep, because during sleep there is no reflex arousal, and if the seizure, especially if the patient is in a prone position, is very dangerous, because maybe the patient passed away if there is no supervision. And as we mentioned that
I'm sorry, you have bad microphone. I didn't hear you, Nermeen. I'm sorry. You have some trouble?
just a moment. You hear me now?
Yes, much better.
You hear me now? Okay.
Yes, yes.
So I mentioned that the most important patient who approach about talking about SODIP is a patient with has a exclusively nocturnal seizure, because nocturnal seizure, especially if generalized, and especially if the patient has no supervision, at a high risk of the risk is increased triple.
Again, we are on the same problem. I'm so sorry.
It's okay.
The sound is clear with us.
No, we are not so lucky. You have
the sound,
again,
Dr. Adel, the sound is clear with us. I don't know. It may be a problem with you.
You hear me?
What?
Dr. Adel, you hear me?
Yes, maybe it's okay.
Okay.
We hear you, Dr. Nermeen. You can proceed.
Okay. Okay. The comment say that the voice is clear. Okay.
Okay.
Can I share, Dr. Adel?
We have from Osama Landuzi, can surgery be proposed in the early course of the disease for a definite subgroup of patients, and what are the inclusion criteria?
For sure, the surgical line of treatment in epilepsy, if the patient has a epileptogenic lesion, there is, I think it must be a surgical candidate, and do as early as possible, especially in the pediatric age group. My sound is clear?
Yes, it's clear, yes.
Okay.
I just want one comment, if Dr. Adel allow me. Dr. Adel, can you allow me to say something?
Yes, sure. You are welcome.
I think the problem of the sound, I think it's with you, not with Dr. Nermeen. Anyway, I just want to raise the point that the first person neurologist who defined the SODIP in the world is the Palestinian neurologist Lina Nashif. You may know her, Dr. Adel.
Yes, she's my close friend now. She is in England. Unfortunately, she left Palestine and she lives in England.
In UK, in UK. Yes. The SODIP is linked to her name. And my question, Dr. Nermeen, is about carbamazepine. Carbamazepine, you know, is linked in a way or another to SODIP. Are there any other anti-seizure drugs which are related now or may raise a bit the SODIP ratio?
Okay, there is some study about the relation of anti-epileptic drugs with SODIP, especially the depolarizing blocking drugs like phenytoin, carbamazepine, lamotrigine, and also lacosamide and rufinamide, not available in our country, but rufinamide also. All of these were claimed, but there is no definite risk, and we must aware of using these drugs, especially on a genetically prone individual. So this drug, if the patient has family history of sudden cardiac arrest, or we notice that there is a long QT interval on routine ECG, we must avoid this medication more better.
Thank you very much. Thank you, Dr. Adel, for this chance you give me. Dr. Adel, you here?
I hear bad. I'm so sorry. I don't know if the problem is generally or just with me. Did you hear me now?
Yeah.
Yes.
Yes. Okay. And I have another question. So what about the Dravet syndrome? If there is, the severe myoclonic epilepsy, did you need or you have some information about Dravet syndrome with the seizure?
Yes, it is in a one study reported that 49% of SUDEP case due to when studying the mortality between Dravet syndrome found that SUDEP account for 49% of the cases. You know that Dravet is sodium channel mutation, and it may be prone for this condition, especially with the polymedication and the drug-resistant epilepsy and the frequency of seizure, even nocturnal seizure.
Okay. So there is no more question. I would like again to thank you, Dr. Namin, for excellent lecture and the presentation, and for your patience to answer all these questions from the audience and the part of me. I'm so happy to meet all of you, Gaib and RNS and Amin and the audience. I hope to meet you again in the next webinar. Right, if you want something to comment.
Thank you very much, and we thank both lecturers. I just want to say that the question of to tell or not to tell about SUDEP is really a problem in our society. In the world, it is no longer a problem because there is internet and a lot of readings the family can know from here or there. In our society, the Oriental, especially in rural areas, I mean in urban areas, or I mean rural, that's not the cities, or that, and if you tell the patient, it is not a problem. The problem that his mother will die earlier, 10 years, so that he will lose the caregiver in our society.
But I think if the patient, the approach for the patient and family must be individualized. So if the patient has really a modifiable risk factor, frank to us and obvious to us, we must discuss by the level of the patient. As we can see the level, if it's educated, not educated, we can, as a doctor, we can transfer the information according to the cultural level. I think it is our rule.
Yes, you are right. Thank you very much for you and for Dr. Adel and for Dr. Ramiz and for Mr. Dennis, who works a lot to present this nice presentation. Thank you all.
Yes, thank you.
And
thank you all.
See you next
Thank you.
webinar. Bye-bye.
Thank you for all of you. And I think we need to discuss early with the patient, especially we have a comment from Dr. Shehnaz. She said that I think we need to discuss early with the patient, especially adolescents. I'm agree with Dr. Shehnaz comment.
Yes.
And I think all of us, we are agree with Dr. Shehnaz.
Yes. Yes.
Thank you, Shehnaz, for your comment.
Thank you. Okay. Thank you.
Bye-bye.
Okay.
Thank you.
Bye. Thank you.
Thank you.
We can close.
Yeah.
And have a nice end week. Hope to you meet in the next webinar.
Thank
and,
you.
Thanks for all of you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.